quite different than several others that you might have encountered. Professor Fushimura?
Yes. Okay, so can I move on to the next talk?
Yes.
Week? Okay, so it's a pleasure to invite Professor Ulrich Sure from University Hospital Essen from Germany. So today his topic is about surgical indications and techniques of cavernous malformation. So would you start your lecture?
Yes, I hope you can hear me.
Yes, perfectly.
And now I hope that you can you see my lecture? I mean, can you see my presentation already?
Not yet, actually. You mean the slides? Not yet.
Yes, my slides. I have to try to again. Okay, what to do? Yes. I try to open my and then okay.
Imad, can you assist?
Yes, sir. Sir, when you click on the green button at the bottom, share.
I try to make it possible. Freigeben. Usually it works.
Yes, it's working.
Okay.
Yeah.
Okay.
It's now working.
I can see the slides.
Yes, we can
Please
see.
make it
So sorry.
slideshow, please. Okay, good.
So I'm sorry. I don't know what happened. So, dear colleagues, in particular, dear Giuseppe and dear Dr. Fleming, I was a little late to hear your entire lecture, but as I expected, it really shows that we all are sharing a hobby for many, many years, which is called cavernomas. And I'm extremely grateful that I can share some of my experiences on that topic with you. So I'm coming from Essen, which is a city in Germany, in the center of Europe. You see here a map of Germany, and in the middle of Germany, there is a region called Ruhrgebiet, which is heavily populated. And in the center of the Ruhrgebiet, there is Essen. And if we draw a circle of approximately 20 kilometers around it, we have 10 million inhabitants. So that is why we have quite a large catchment area and one of the largest departments within our country. So my today's topic is cavernoma. I included a little bit imaging because I think it's very important to talk a bit on that. Surgical indications and techniques. I definitely have no conflict of interest. As you can see here, it was my early on I started research, also basic research on cavernous malformations, and maybe up to date I published about more than 70 Medline papers on cavernous malformations. And when I took over the chairmanship in Essen in 2008, I built up a international national referral center for that disease, which led to the fact that we were treating quite a very high number of patients. And as a matter of fact, nowadays, we would look over more than 2,000 outpatient clinic. And we have a quite well-documented database, which is mainly done by my collaborators, in particular, Philip Dammann. There is a cooperation, Dr. Fleming also quoted that, with the Mayo Clinic, but also with the Scottish Cavernoma Register and the BNI and also others. So when we look at our own data, these are data from 2020, I just wanted to make a point that approximately 20% of the patients that we are talking about have their problem or have the cavernoma localized in brainstem, according to our data. And when we look into imaging, it's interesting to note, when I took over the chair in 2008, I found Erwin Hahn Institute here in Essen that was one of the first to perform 7 Tesla imaging in humans. And we started early on to look at them in detail. And you can see here, for example, a close-up image of a normal human being that nicely shows how exactly particular venous images can be made by, for example, SWI imaging. And so we use this technology, the 7 Tesla technology, to clear some things that I think are important. And also Giuseppe mentioned some of them already. All of you know that there are particular single lesions that are associated with developmental venous anomalies, a typical Caput medusa-like venous malformation that you can see on the right side here. But if we talk about sporadic cases, that means patients with just one cavernoma, I can tell you that if you look at 7 Tesla in SWI, you will also find something like you see on the left side here. This is what we call a typical venous atypia. So in sporadic cavernomas, you would find them in 70%, and in sporadic cavernomas, you would find a DVA in 30%. That is important to know. Now, if we look at patients that are diagnosed with multiple cavernomas and we look at their genetics, using the 7 Tesla data, we also find out something which is quite noteworthy. Look at these images. You saw the one already before. You see a DVA here, and you see several cavernomas in the neighborhood. And now look at this image. You see a lot of cavernomas in this patient, but you wouldn't see a DVA in this case, in this patient. Now, if we go into detail and we would check their genetic state, we would find in the above patient one of the mutations in one of the known genes, CCM1, 2, or 3. In contrast, we wouldn't find them in the lower case. And this is true in 100% of each patient, which tells us that if we look at the image like that, we can be absolutely sure that here there is a there is a genetic alteration, except when the patient has been irradiated in infancy due to malignancy, whole brain radiation. And if we see multiple cavernomas in the neighborhood of a DVA, these patients wouldn't have a genetic disorder. So only by imaging we can distinguish these patients. Next, I would like to talk about indications, when to treat cavernoma. And let me start with the incidental cavernoma. So what do we know? I would like to show you one of the most important publications that we did. And this is on health-related quality of life in untreated cavernoma patients. These patients suffer a decreased quality of life compared to normal population. This is very important to know. And Kelly Fleming has already shown that there is a quite very low risk of hemorrhage, which is said to be 5 to 6% in patients that wouldn't have hemorrhage before and would have incidental cavernoma. These are the data from our own databases that shows a cumulative 5-year risk of all patients of only 7%. If we look at the natural cause, even in a 10-year study, the 10-year follow-up, we can see what Dr. Fleming has already shown. Those patients who had a hemorrhage before, have had a hemorrhage before, have a higher risk than those who wouldn't have such a hemorrhage. And also quite interesting, I will come back to that in a minute, is that patients with a cavernoma in the spinal cord would have quite definitely very much higher risk of rehemorrhage. So what should be the management of an incidental cavernoma in our view? It's very easy. We shouldn't touch it. And I go even a step beyond. We wouldn't even follow them. So we wouldn't follow them by a 1 year, 2 year, or 3-year follow-up. In our hands, we would not recommend a regular follow-up unless there's a clinical event. Then we would advise a MRI follow-up. So in conclusion, for these asymptomatic cavernomas, remember they have a decreased quality of life, and it's you that should consult the patients to make clear that maybe they shouldn't be so anxious, and you could help to increase their quality of life. And we at least wouldn't advise a follow-up unless there is a clinical problem. Dr. Fleming has shown it: hemorrhage, higher risk, and deep localization, particularly in brainstem, very high risk, which can be, there are publications that say 30 to even 60% per year. Dr. Fleming also spoke about other risk factors such as obesity, developmental venous anomalies, on the other hand, wouldn't increase the risk of hemorrhage. Also important to know. And here you see our common publication that also was quoted already by Dr. Fleming, the topic of female hormone therapy. There's also another interesting question. What's about the familiar and the sporadic cases if you compare them by the risk of hemorrhage? And this is very important for the families, members of families of genetic cavernoma disease. They wouldn't have definitely much more high increased risk of hemorrhage unless that they would even harbor more than 10 or 20 cavernomas. The same is true for children. Children wouldn't have a higher risk of hemorrhage when compared to adults. So if we speak about what is a very good indication for treatment, I can tell you a very good indication is epilepsy, and particularly if the cavernoma is localized in the temporal lobe and even more in the temporal mesial lobe. So what to do when a treatment is indicated? There are particularly a lot of papers on radiosurgery and surgery. My comment for possible radiosurgery is there are pros and there are cons. I always advise not to do radiosurgery. Reason is that cavernomas can be caused by radiotherapy, number one. And also, I unfortunately had to operate on dozens of cavernomas that had been irradiated, particularly by gamma knife, and had partially severe rehemorrhages. Dr. Fleming also quoted the CARE trial that has been enrolled in England or in Great Britain, that has been published in very recently. Those of you who are interested, look at it. But I must say that reading the first report on that, I'm very preoccupied, because not only I am very preoccupied, also other neurosurgeons, because we really want to avoid a Ruber effect, because the CARE trial so far only includes a very atypical panel of patients treated, for example, mainly by radiosurgery. And for that reason, also Giuseppe and I, we share another publication. We wrote a letter to comment on that. Maybe those of you interested, have a look on that. That has been published maybe 4 weeks ago. Epilepsy, this slide should have been shown before, sorry. Epilepsy, I already told you, is a very good indication. Why that? We looked prospectively at patients who were treated and those who were not treated surgically. And I can tell you, the patients share after 5 years have absolutely the same morbidity by the disease. The difference is those who were operated wouldn't have had any more hemorrhages and wouldn't have epilepsy any longer and wouldn't take drugs. And for that reason, this shows that epilepsy is a very good indication for surgery. The outcome is very good after that. And if it is possible, talking about the epilepsy, about cavernomas in non-eloquent regions like this one, you should remove the hemosiderine rim like here. Here, a very short video of this superficial, very easy case. This is a video that is several years old. You first remove the cavernoma, and then later you remove all these hemosiderine rim-like tissue when you are treating epilepsy. Then you would have the best outcome. Another very good indication is deep localization, because these lesions bear the high risk for rebleeding. And I just show you now some of the cases. You see here mesencephalic cavernoma reaching the surface at the dorsal rim of the mesencephalon and pons. I operate these lesions usually in sitting position, and it's really honestly quite easy to remove them using the gravity. The cerebellum slacks down, and it's easy to remove such a case like shown here. And typically the patients are immediately better after surgery. In this case, the hemiparesis resolved within days. Another case of a pontine lesion. Here, please note that it comes close to the surface on the lateral, and therefore a subtemporal transtentorial lateral approach is used. And same is true here. Hemiparesis is better very early on. However, when we're treating particularly brainstem lesions, you can see the numbers of this meta-analysis here. Long-term harm in 15% and mortality even in 1.5%. When I look to my own series, these are the numbers of 2020. I must say that my numbers are a bit better. However, we must admit that, of course, there's even a morbidity after surgery of deep-seated lesions. And we looked in our brainstem cases, and we asked the patients, how many of you would do surgery again? And it's interesting to note that far more than 90% would opt for surgery, to do surgery again. However, we must be aware the average time to return for work is approximately 9 months. And there's one more thing that I want to make a point of, and this is this image that you can see here. I don't know if anybody of you is aware of what this is. Of course, this is not a cavernoma. This is a so-called hypertrophic olivary degeneration, and this one was created by myself when I operated on this cavernoma here that had bled twice. And I operated it after the second symptomatic hemorrhage. And the patient went home fine, very fine, but he returned several months later with an extremely severe dentorural tremor, which is extremely disabling, and an ocular myoclonus that is absolutely problematic. And why that? Why happens that? We know that this is due to a problem that we give in between the connection of the dentate and the red nucleus. And therefore, the so-called Guillain-Barré triangle is altered. The connection is partially destroyed, and this gives this hypertrophic olivary degeneration that typically arises only months after the treatment, and which is severely disabling. We collected a number of cases, altogether 20 cases, and my friend Marco Censato from Milano published that also in Journal of Neurosurgery in 2020. These individuals are severely disabled, and that we must be very aware we can cause this problem. Talking about deep-seated brainstem cavernomas, I think it's very important to look at the outcome of them in detail. And we did that and have also published that. So those of you who are interested in that, have a look at this, at these publications. Because if you opt to do such things, to remove brainstem cavernomas, you should be aware of that. And since it's very difficult to provide treatment recommendations, we performed the Delphi consensus. And also, thank you again, Giuseppe, you took part, but also a number of other quite famous international colleagues. We performed the Delphi consensus when we would recommend to do what. If you're not absolutely sure what to do in an individual patient, have a look at this publication. I always like to show this image. This is a 7 Tesla of a quite rare incidence. This is a hemicavernomatosis of the brain. I saw 2 cases like that in my career only. And I like to show that because I make a point out of that. If you see a patient like that, it becomes quite obvious. But be aware, if you treat a patient with multiple cavernomas, you can never heal that patient by removing one of them. And for that reason, you should be very defensive in surgical treatment of patients suffering from multiple cavernomas. Now, talking about treatment of cavernomas, I think it's always necessary to show something like the worst case. This is my worst case that I treated many years ago. Patient suffering from hemiparesis, which was coming and going several times. He had maybe 6 or 7 hemorrhages in that cavernoma. And finally, I decided to remove it through a Transsylvian approach. This was a very beautiful surgery. However, when I had removed the cavernoma in the end, I had a bleeding, very small intraparenchymal artery, and I tried to coagulate it for maybe 40 minutes, but it was not possible. So I had to leave a shunt clip. And in the end, the patient developed infarction that gave a nearly complete hemiplegia to the patient that remained. So that shows very much that it's very severely that we can cause, and that we always should be aware what we do, and that we should always do a risk stratification. We must stratificate the cost for the patient and the benefit for the patient. So I want to draw a first conclusion before I show you, if you're interested, 3 or 4 more interesting cases, also talking about surgical technique. But according to my belief, we should not treat incidental cavernomas. We wouldn't even follow up them. The treatment indications, as I've shown you, should always be guided by a strict risk stratification. And be aware, the surgical risk is determined by the localization of the lesion and also by the approach. The risk of hemorrhage has been mentioned now. What gives risk has been mentioned a lot, but particular deep localization and previous hemorrhage. Epilepsy is a very strong indication for treatment. Deep localization, very strong indication. There's a restricted indication for multiple lesions, and once again, always counterbalance the risk versus the conservative management. Now, let me show, Giuseppe, it's okay when I show...
Yes, please go ahead to show some cases, especially if you have videos, and you know, we're interested how you think about the surgery and even some basic aspects of the microsurgical techniques. Absolutely.
So this is a case that I wouldn't treat nowadays. I treated that maybe 15 years ago. You can see this is a case from a family, and the patient had an MRI and a growing capilloma here, and she was afraid to have a blockage of the foramen of Monroe. And we had a lot of discussion, and look, you can see a capilloma here, and you see also one here. And in the end, you know, after long discussion, I removed it, and I just wanted to show you this is left-sided. So I did a interhemispheric transcallosal approach from the non-dominant right side. You can see it maybe here again. Interhemispheric, you see already I do the navigation, and I open it from the right side. I open the contralateral ventricle by callosotomy, and then it's quite easy to remove the case. And then, of course, I check the arteries in the end, and the patient did very fine. But she came for a follow-up MRI 3 months later, and this is a 3 months later follow-up. This looks nice. This was an immediate post-op, and but look at the 3 months later, and she drove crazy because she had a. This one is removed, and she had a hemorrhage in between in the other one. And she drove completely crazy. So, and this is now left side, and she kind of forced me to also remove the asymptomatic. This was asymptomatic. This was done on follow-up. And I did it, and I removed it, and it went quite okay, as you can see here. But this, from my experience nowadays, I wouldn't have treated this one, and I wouldn't have treated that one. That is why I like to show the example. Here's another one, 19-year-old case, I think 4, 5, 6 years old. And she had 4 hemorrhages in 1 week, and she was hemiplegic and aphasic. Now, look at these images, and we are talking about approaches. What would be an approach to remove this image? Would you go through the insula, or would you come from temporal, subtemporal, or would you come trans-sylvian, or would you consider to do supracerebellar transthalamic approach? Well, I consider to do the same thing that I showed you before. I did the contralateral interhemispheric transcallosal transventricular transthalamic, and this is an immediate post-op, and the patient did extremely well. So the aphasia was immediately resolved, and the hemiplegia resolved completely within 3 weeks after the surgery. Now, let's look at this one. Another basal ganglia one. I think I treated last year, and I was considering a trans-sylvian approach. Very important, particularly for deep-seated instruments. These are my special instruments that I use, even quite long ones. We did a typical frontal craniotomy. This is double size. I'm not so hectic in surgery as it looks here. And maybe I can go a bit ahead. I open the Sylvian fissure. And if I would show you now the entire video, you would recognize that I now see M1, M2, M3. And my first plan was to enter above the M1, but above the M1 and above the M2, there were small upcoming. Here you see one of them, some very small upcoming cortical suppliers, and therefore, I came from more lateral, and go to see when I'm now in the cavernoma, and this is a very high magnification. And what I like to show here is I use only coagulation for the lesion itself to shrink it and to make it a little bit more hardened, and then I pull the lesion in the cavity that was created by the lesion itself. Yeah, and when I see a very small vessel like here, then I cut it. Okay, but usually I wouldn't do any more. We can see a small venous lesion, a venous vein here. Yeah, I coagulate and then cut it, and by pulling that, we can then later can come down. Okay, this was already a third ventricular case. That's sorry, I skipped the previous one. This was a third ventricular case that I did also through a transcallosal approach here, and then stitching the falx, opening the ventricle, and opening the third ventricle here, and then you saw before what I did. I shrinked it, I pulled on it, and I pulled it in the cavity. Yeah, and in the end, the lesion is then gone. I'll show that. I think here you can see the I think you can acknowledge it. This was pre, and this is, I think this is post, when the lesion is completely removed, and the patient was fortunately doing fine, although there are a lot of risk of cough, of course, due to the localization. What I usually wouldn't do, so this is a quite old case again, I wouldn't do, if I can avoid that, I wouldn't do telovelo or transventricular false ventricular approach, because like in this lesion, because as you can see here, the stria medullaris are below. Usually what happens if you remove like this, you will give the patient some harm, either it's the 7th or the 6th or even both nerves. So in more recent cases, I wouldn't do such an approach. This is a post of this region. I would usually do another approach recently, and this is what is called in American literature the far lateral. This is a publication of Michael, and he does it in park bench position. I do it in a sitting position. So this is the same images, his view, my view, and you see this case here, for example, a lesion that is quite ugly because it's reaching the ventral surface of the pons. And come on, I don't know the view. This is a positioning of the patient. Skin incision, craniotomy, opening, dural opening, and now opening. You see the caudal nerves, and you can see here where it reaches the surface, and you see my super nice bipolar. I don't know why the video doesn't doesn't run. I have to run it like this. And here you will see the same thing. I always push it and pull it in the cavity, and then advance it as low as less as few as possible bipolar, and then in the end it comes out completely. And here is another case. I think this is the last case that I would like to show. So this was in, I don't know why it doesn't run. This one runs. 2016, look at that. And that what is happening. In 2019, it had several hemorrhages and reaches the surface now lateral below. So same approach, far lateral approach, drilling a bit of the condyle, and then opening the dura, releasing the CSF. And now we can, below the cranial nerves, you can see the lesion on the surface. Then you use the colorized surface, again my bipole, and I'm going to advance it a bit. So the same thing. Sorry, the same thing that you can see here. I push it and pull it until in the end I can remove it. Somehow the video doesn't work properly. I'm very sorry for that. Maybe even a rest, and I also like to leave some surgical cell in the end, and the patient is then should be then fine after surgery. Yeah, that's it. I thank you very much for your interest in our work and in cavernomas. And I'm, of course, open for any questions. And once again, I have to apologize for the video. There's some problem with my software. It looks like that. Thank you, all of you.
Thank you, Professor Sure. It's a great talk about, comprehensive talk about the surgical aspect of the cavernoma. So before moving to the general discussion, let me give a couple of questions before that. So the first question is, you indicated the decreased QOL in the asymptomatic cavernoma. So what is the mechanism of the QOL decline in patients with asymptomatic?
What is the can you please?
Mechanism, yeah. Why? What is the reason that the asymptomatic cavernoma patient has a decreased QOL? Because the patient is asymptomatic.
Yeah. The QOL, quality of life.
Yeah.
The reason is that usually the patient, let's say, would have a headache, and a colleague would then perform an MRI. And then the patient is found with a vascular lesion. Mm-hmm. And then the radiologist tells the patient, oh, you have a vascular lesion. This is prone to hemorrhage, or even maybe has had a small hemorrhage already. And that gives a lot of stress to the patient, because the patient maybe would have fears that he or she would have a hemorrhage that gives severe disability to them.
Thank you. I understand. My last question is, it's interesting, you don't recommend the MRI follow-up for the asymptomatic case. I understand. So my question is, how often do you follow up for the post-operative cases? Every 6 months, or maybe it depends on the surgery?
No. When the post-operative cases, we follow up after 6 months once.
Okay.
And if the cavernoma is removed completely after 6 months, by the way, it doesn't make sense to do it 3 or 6 weeks after that, because we can't be sure with the MRI after 3 or 6 weeks. But after 6 months, if the cavernoma is removed, that's it. No more follow-up.
No more follow-up. Okay, okay. That's your problem. Okay, so Professor Lanzino, you can move to the general discussion.
Yeah, we can move to the. I was monitoring the chat. I don't think there are questions. I'll like to make a couple of comments on the surgical approach, particularly to brainstem lesions. And this is, of course, the webinar is steered toward our younger colleagues. What I've learned is that quite often when you go there, especially if it's the cavernous malformation, there is not a hemorrhagic component. You get the impression that the cavernous malformation is really stuck to the surrounding brain. And but what I learned, as you do the piecemeal resection, and then you start going, you start pulling the cavernous malformation. If you are patient, the brain itself, the brainstem will as it will start compressing the remaining cavernous malformation toward your opening, because when they bleed, the cavernous malformations distend rather than destroying the surrounding brain. So I learned that it's important to be extremely patient and careful, especially in the initial parts where you get the impression that the cavernous malformation is terribly stuck to the surrounding brain. And the other thing that I'm always amazed is that as you go, you see often a small portion of the cavernous malformation comes to the surface, and you enter there, or you do a small incision through so-called safe entry zones. I'm always amazed as you proceed in the resection, your opening actually naturally enlarges. And the other point that I like to make, I cannot stress enough the importance that Professor Sure mentioned, how to be careful about the fourth ventricle, because truly when I look at my morbidity after surgery for brainstem cavernous malformations, doesn't seem to be related to long tracts. It's not hemiplegia or hemiparesis. It's not so much specific cranial nerves, but it's mostly the associated fibers, the medial longitudinal fasciculus. Patients develop funny high symptoms and constant sense of disorientation in space. And the other thing is that, remember, the cavernous malformation displaces rather than destroying surrounding brain. So you will be amazed at how much normal parenchyma is there, even though when on the MRI you get the impression that the cavernous malformation, it's very close to the surface. After you remove the cavernous malformations, again, you realize that there was much more parenchyma than you thought, and that's because, of course, the parenchyma was extremely compressed. We can proceed with Professor Fujimura cases now. Looking forward to those.
Oh, I don't have a specific case today, but yeah. My question, I have one question about the hypertrophic olivary degeneration. I learned a lot from your lecture, and my question is, what is the exact incidence of this deleterious complication? Because you have a huge series, so you know the incident. Yeah. Is it very rare, or sometimes happens? Or?
Yes, I can say when we checked our cases, we had I think 120 cases. We had 2 severe I showed you the most severe case before by imaging. We had 2 severe cases, but we had 2 other cases who were also quite, maybe not absolutely severely, but disabled, who had a very similar thing. So, and when you speak to Robert Spetzler, he has seen also the same thing. I think he has contributed 4 or 5 cases, but in case of the Spetzler series, it's a bit difficult because he treats a lot of international patients, so follow-up might not be absolutely complete after years. In my series or in our series, I would say we would have a quite complete follow-up. So it should be something between 1% and 2%. And also interesting is, as you have seen, the lesion that I have shown you was a quite straightforward lesion, wasn't it? It was on the dorsal surface of the midbrain, connection to the pons. Yeah, but this is very close to the upper cerebellar peduncle, and I think, or I know, of course, that the Guillain-Moiré triangle, the connections, the fibers, they are running here. We must be very aware of that. And I think what is so absolutely bad is, you know, the patient is feeling very good after surgery, better than before. The surgeon is feeling good because he helped the patient, and then a couple of months later, you meet such a patient who comes in a wheelchair, which is very bad.
Okay,
1-2%, I would think.
1 to 2%. Okay, thank you.
Very good. If we don't have any more questions, I'd like to thank the participants, my co-moderator, and Professor Sure for another great presentation on the topic, and for sharing his incredible experience with this disease. And I also invite everybody to join us for the next webinar. It will be on November 23rd, and the topic will be global neurosurgery, especially as it applies to cerebrovascular surgery, challenges and opportunities. Thank you, everybody.